Today we are going to discuss a special case which is about Cholecysto-Colic Fistula, and I am Dr. Gaurav Mittal, Senior Consultant and Unit Head in Shanti Mukand Hospital. I do my special interest in laparoscopic surgery and pediatric surgery and thoracoscopic surgeries. Recently we did a challenging case of Cholecysto-Colic Fistula. This patient is of middle age, around 50 years, and she came with a history of recurrent pain in abdomen with nausea and vomiting off and on. She doesn't have any history of diarrhea or any jaundice, and we worked up this patient for gallstone, as she is having gallstone ultrasound, and she was under the process of surgery, but one day she has acute pain, and because of which she was admitted in emergency, and we planned the surgery. And this patient, when we explored on operation table, we realized that this case is a special kind of having Cholecysto-Colic Fistula, as this disease per se is not being diagnosed in any investigation. This is an incidental finding, and this is a very unfortunate or undetected thing. If we are not careful to dissection in surgical dissection, then this can lead to so many complications. So when we put the scope inside, the gallbladder was totally covered with momentum, and the duodenum was densely adhere, the colon was densely adhere. We slowly dissected and moved all other surrounding structure which is being lying with the gallbladder. Momentum is being dissected well off, colon is dissected in the proximal distal part, and the duodenum is dissected. But the part of the colon was densely adhered with the wall of the gallbladder, and we were very meticulously and gently dissecting the structure. And it came out that there is a connection between the gallbladder and the colon as a cholecysto-colic fistula. As when we dissected this further, then there is an opening to the colon and opening into the gallbladder, which confirmed that there is a connection, there is a fistulous connection, and which was dealt laparoscopically. And the hole which was in there, which is there in colon, is repaired with laparoscopic endosurgery, and the gallbladder was dissected throughout its length, and it is being removed. The post-op patient went well. This patient was, normally we keep a day for post-op in a gallbladder case, but this patient was we kept for 2 days in the hospital, and there's a minimal we kept a drain also, which is being removed after 48 hours, as the patient was not draining any significant amount of fluid. And now the patient is fit and fine. She has been consulted and follow-up. All sutures has been removed. She is doing well. This case of Cholecysto-Colic Fistula is unique in the sense that it is very difficult to diagnose pre-operatively. No investigation, including the ultrasound, CT scan, the magnetic resonance collegiopetigraphy, this MRCP which we say, these all investigation can't diagnose this test. Only sometimes the symptoms, one symptom is diarrhea, it is being chronic diarrhea, that can present with Cholecysto-Colic Fistula, but that just indicates that the patient can have a fistula, but it can't diagnose. So this is an incidental finding most of the time, and this is unfortunate even if you are not mentally prepared or you do not have a surgical acumen to deal with it. And the high index of suspicion when you are dissecting the tissues in that plane makes your diagnosis and give the fruitful result. Otherwise, it may come as a disaster, as a colonic perforation, if you have not noticed it. So this was a challenging from the surgical point of view, but with the team, the colleagues which we have in our OT, the staff, the anesthetist, the support which we have in Shanti Mukand Hospital, all because of that we are able to finish this surgery and this patient went well home and everything is went well. So this is just for information. Thank you. We are always there to support and